Thanks so much for tuning in today. My name is Katie Beachy, and I work with the American Cancer Society. And we are so glad that our coalition partners around the country have tuned in for today's webinar on understanding lung cancer screening guidelines. What does it mean as a coalition to promote guidelines when there's been updates? I hope that you are well aware that ACS works very closely with CDC National Comprehensive Cancer Control Program. We have a cooperative agreement with CDC to offer training and technical assistance, and we've had that in place for over 25 years. We're thrilled to be closely partnering with CDC on today's webinar as well, which you'll see with the involvement of Nikki Hayes in just a moment. But what I wanted to start out with was, we hope you didn't miss it last week, that there was a wonderful webinar hosted by the National Lung Cancer Roundtable here at ACS. And we have the link here. We'll also drop it in the chat and send it to you as follow-up. And that 1-hour webinar went deep dive into the clinical guideline update for ACS. It would have been great prep for today's webinar, but you can always watch it as follow-up. What we wanted to focus on today instead was, yes, understand what might be an update to the guideline from ACS, but moreover, really just refamiliarize yourselves with lung cancer screening in general. As a coalition, where will there be opportunities for you to increase awareness of lung cancer screening recommendations, no matter what guideline that you're discussing? How can you promote appropriate lung cancer screening? We're also going to give you some examples of lung cancer screening objectives and strategies from state plans, and hopefully acquaint you with some resources that are out there for you to follow up with your coalitions. So we don't only have an hour, we have great panelists. I want to jump right into our discussion panel. On the screen here, you'll see the lovely folks that have agreed to be with us today. We have Dr. Bob Smith from the American Cancer Society, Nikki Hayes from CDC, Dr. Michael Pignone from recently that is working with Duke Medical School, and Jennifer Redmond Knight, who's with the University of Kentucky, among many other hats. And what we hope to get through this panel are some clinical insight, some coalition, frontline coalition insight, and then of course, insight from CDC, who does funding for most of this comprehensive cancer control work. So we're so glad that you all are here. I'm going to stop sharing, Liddy, and if you could pull up our panelists, we're going to get kicked off with a question. A little housekeeping. As you know, you are welcome to put questions in chat. We will be following those questions. But before we do that, let's take a quick poll. During this poll, we want to know how confident you feel, essentially, in promoting lung cancer screening guidelines. So do you know how to promote both ACS and USPSTF lung cancer screening guidelines? Just a quick little pre-poll. And then we're going to ask, once you're done with that, scroll down. There's another question, just 2 in this poll. If you don't measure it, it didn't happen. So we have to have a poll. We hope you'll stick with us to the end so you can answer this at the end of the hour. And as you're doing that, I'm going to have Disa pull up the slides for Bob, because our first discussion panelist is going to be Dr. Bob Smith, who's a colleague of mine here at ACS. He and Ella did a wonderful job last week doing that deep dive into the lung cancer screening guidelines. I asked him to just kind of give us a recap, like an overview of what he shared, just to level set for all of us. And then once he's done with his slides, we'll pull the entire up and get some vigorous conversation going. So Bob, take it away.
Thanks, Katie. We can go right to the next slide, but thank you all for joining us today. We have a very different kind of discussion than we had the other day. So the ACS updated its lung cancer screening guideline in just last week. Our last update was in 2013, the major update, which is the guideline that came out right after the NLST results were published. Then we basically followed the recommendations that were in place for the NLST for its eligibility, that adults had to be between the ages of 55 and 74 with a 30 or greater pack year history, including those who had quit smoking previously and were within a 15-year window of having quit. Um, in this update, we decided that we needed to look more carefully at the years since quit requirement, and that's what I'm going to discuss today. Next slide, please. So these are the new recommendations, and just for reference, we compare them to the Presumer Services Task Force recommendations, which were updated in 2021, and which are the basis for coverage under the Affordable Care Act. As you can see, they are really quite similar. They have the same age range, 50 to 80. They have the same PAC year history. This part of the recommendations were modified in 2021 following the publication of the Nelson trial, which was conducted in the Netherlands. And they recommend annual screening with low dose CT. The one difference as a result of this update is that the American Cancer Society removed any consideration of time since quit among people who formerly smoked. Next slide. This actually shows you just a quick history of these guidelines, and it shows you the consensus that exists really presently with most of the organizations that recommend lung cancer screening. There are three organizations that don't recommend years since quit criteria and be included in the guidelines. That's the National Comprehensive Cancer Network, the ACS, and the Association of Chest Physicians also has one of three options that does not include years since quit. Next slide. All right, this is a paper that was published by Michael Halpert and colleagues in 1993, and it's a paper that I recalled when we started our guideline update. And what you see here, and I think which is really quite important, is that Michael and his colleagues showed that the younger you are when you quit smoking, the more you are going to reduce your overall risk of lung cancer. And what he also showed is that when you quit smoking, your risk of lung cancer flattens out a bit compared to continuing smoking. And this is a fundamental message that we would give anybody who smokes, is that it's the single most important thing you can do to improve your health. And especially in comparison to someone who continues smoking, your risk will drop dramatically. But we've always believed that it just continues dropping, that with each year since your quit date, your risk drops substantially. And this turns out to not actually be true. And you can see this for people, especially who quit a little bit later, had a longer history of smoking, that as they are continuing to age, that risk actually starts climbing again. And when we examine these data more carefully, and especially with the contribution of our colleagues at the NCI and our colleagues with in the CISNET group, we saw that, in fact, that the same pattern of flattening out and then increasing was evident in the PLCO data, the NLST data, the National Health Interview Survey data. And in fact, for a person who has a 20 PAC year history and has quit 15 years previously, their lung cancer risk can be increasing as much as 9% per year as they get older. Next slide. And what would this look like today? Frankly, this is kind of a complicated slide, but it's not going to be so complicated as I walk you through it. So this is a series of modeling of the percent eligible in the population for screening based upon the current guidelines and different patterns of years since quit. As you can see in this legend, as the Preventive Services Task Force line. And then the other ones are the ones that look at 10 years since quit, 15 years since quit, 20 years since quit, 25 years since quit, and no years since quit. And so what you see happens is that very few people are actually excluded from screening based upon having achieved a 20 PAC year history of smoking and a 15 years since quit, all before the age of 50. This is going to make a lot of sense to any of you and all of you who were in high school and remember what a struggle it was for yourself or anybody else you knew who was smoking to actually have a cigarette or a half of one at any time during the day. you're under a great deal of supervision until you reach the age of 18 or 19. Then you would have to pack in 20 pack years before the age of 35 to actually be ineligible to start screening under the Affordable Care Act. So what will happen is that most people will lose eligibility for insurance coverage after the age of 50 if they have achieved that 20 pack year history. And what happens is that people will start screening and then they will lose eligibility. And this pattern is really quite stark under a 15 years since quit recommendation. So that bottom line shows the number, sort of gives you the impression of the number of people who will drop out from screening, especially as they approach the age of 65, 70, and 75. And that's one of the things that this change in our recommendation will do, is it will actually swell the proportion of the population who will be eligible for screening into that older age group. Now, there's a lot of concern, of course, about eligibility and overall health status, but keep in mind that people who have quit smoking generally regain a great deal of their overall health status. In fact, people who formerly smoked tend to be pretty adherent to preventive health recommendations. So we would presume that people, not we would presume so much as that we would hope that referring physicians would be attentive to recommendations that have existed for everyone since the beginning of recommending lung cancer screenings, that patients have to have a reasonable expectation of good longevity. They have to have really no life-limiting comorbidity. Otherwise, you increase the potential harms when you refer them to lung cancer screening. And what the modeling that was done for this update showed is that when you actually can reliably and that's a challenge. Dr. Pignoni can certainly attest to that. When you can reliably predict that a patient has at least 5 years longevity, you will cut the harms associated with lung cancer screening virtually in half. In terms of maximizing benefits and limiting harms, that ability to really seriously consider the overall health and longevity of the patients you're referring to screening is really quite important. Next slide. Presently, so the question is how many people will be eligible for screening? Presently, about 14.3 million are eligible for screening under the 2021 Preventive Services Task Force recommendation. The new ACS guideline is going to increase that number by about 5 million. From roughly 32% of those who ever smoked to 43% of those who ever smoked. Next slide. So I guess in closing, what we have observed is that guidelines have been loosening since 2013. And what we've also observed over time is that we've set the risk bar relatively high. And we're learning more and more about people who reach, I think, relevant absolute risk levels at younger ages and with lower pack year histories. And there certainly are other risk factors that in the future ought to be brought into the equation of referrals for lung cancer screening so that we can actually reduce preventable deaths in a larger fraction of those who are at risk. And I think it's quite urgent given the magnitude of this tobacco epidemic that has been a result of, frankly, a predatory marketing approach to get people to start smoking when they're most vulnerable. And that results in them being at significant risk for lung cancer in their adult lives. We have this window of opportunity, and we need to rise to the challenge not only to identify other contributions to risk that ought to be brought into the recommendations, but also to overcome the rather dismal record that we have today in our uptake of lung cancer screening. For the first time, really, in our professional lives, we have something to offer people who ever smoked. Historically, our approaches to tobacco control have been keeping people from starting smoking and helping them to quit once they have. Now we have the ability to detect lung cancer early, and we have a virtual revolution in therapy for lung cancer screening, and it's time for us to put our best foot forward. Thank you very much.
Wonderful. Thank you so much, Bob, for that great and succinct overview of the changes from the ACS screening guideline for lung cancer screening. So now that we have that common denominator, we've all been brought up to speed on the lung cancer screening guideline. I'm going to ask Liddy to bring up our panelists, and we will take questions from the chat, and we'll also take some questions that were sent in beforehand. So I think I'll start with that. So Jennifer, let's cut straight to the chase here. I'm going to ask you the first question. What do you feel like are best practices for coalitions when they're promoting screening? If guidelines differ, what should they focus on?
Well, I think one of the key things is to focus on what's the same rather than what's different. So I think one of the tendencies is you're like, ooh, that's different. And it almost like it creates additional conflict. But how can we focus, first of all, on what's the same? I think the other piece is knowing your audience and who you're talking with. So if you are talking with health professionals and organizations working with health professionals, then having some honest conversations about here are the guidelines, here's how they compare, here's some considerations of them, and having that open dialogue. If you're talking to the public and you're like, here's a table of all the different guidelines and how they differ, then it's going to be really confusing. So I think you need to get clear on your audience and then share that. And, you know, similar to what Bob had put, and I even created a small one of my favorite things is to create a really nice table as you're kind of presenting to coalitions. And I can try to share that, but something just very similar, again, to what Bob had. And that is, you know, here's how they compare. Here's where you can go to learn more. Here's some insurance coverage, just answering some of the common questions and having an open dialogue with your coalition focused on that area. But when we're talking with those who are reaching the public, we don't need to say all the things. We can say, here's what we know, and let's focus on a guideline that we feel comfortable with, and let's go in that direction.
Great. Thank you. Dr. Pignone, before we got on the phone, you were talking about something similar on focusing what is common amongst us. How do you think this expanded eligibility in the one guideline will just overall impact the number of people we're able to screen?
That's a really good question. I really do want to reinforce the point that there's a huge amount of agreement between the different guidelines. And given that our overall success rate in getting people who are commonly eligible screened is about 20%, that's really where my mind is and my heart is, honestly, every day is about equitably reaching the majority of the population that we have agreement about. And I think all the panelists have expressed agreement with that underlying philosophy. And you know, unlike some of the other areas where I've done work like colorectal cancer, we've got a long way to go in lung cancer screening. So really, you know, to Jennifer's point, focusing on the common elements. And I think I want to applaud the work of the ACS guideline group and all the entities, including CISNET, that supported it. Because I think the point about people's risk not decreasing you know, necessarily right, like doesn't fall off the cliff right 15 years after they quit is an important point. But in implementation, it's getting people in and keeping them in programs and then delivering safe, high quality, culturally appropriate services so that people feel welcomed and, you know, get good screening that is accurate and safe. And very importantly, get through the whole cascade. So if they have positive findings, that we have a good system for getting them further diagnostic testing and then treatment. And, you know, having spent the last 7 years in Texas, where uninsuredness is rampant, what I worry most about is just making sure that everyone has access to these services, and not so much the people at the decision making at the margin, because we have mostly agreement.
Thank you. Thank you. Nikki, would you have anything to add to what's been said so far before we move along?
Thank you. And thank you to you, Bob, and to all the panelists. This is an awesome opportunity for our coalitions to to engage the experts. And so I thank you all for the questions. I beg you to keep them coming, because we have all the right folks in the room today to be able to answer them and respond. And I agree with everything that's been said. And I especially want to highlight Jennifer and Michael's comments about really focusing on what we know we do, we all agree on, because of the fact that the screening, there's such an opportunity for us. Screening rates are so incredibly low. And so let's focus on what we agree on so that we can get folks the screening and the services that they need, especially when we know and understand the true burden of this cancer in our communities, especially those communities that we know are underserved. And so let's work together to figure out how we can move forward with what we know, and then we'll do the work that we need to do on the back end to kind of catch up and see where we can even do more to even bring the recommendations closer together.
Thanks, Nikki. That brings up a good question for those of us that have been in the public health subculture for as long as we have, Nikki and Jennifer and others. You know, another opportunity we had back in the day was, and a lot of momentum was around colorectal cancer screening and educating the public and providers about those guidelines. What lessons, does anyone have something they want to share, a lesson learned from raising with providers and with the community? We're kind of at a Chronos moment here for lung cancer screening in a similar way. And where is the opportunity? It can seem overwhelming for a coalition just embarking on this kind of awareness.
I'll go ahead and start. I mean, one thing that's quite different is that we've got a very narrow and unique group of people that we're targeting. You know, for those of us who were active, were working when breast cancer screening was ramping up and colorectal cancer screening, we depended a great deal on this interaction between patient and healthcare professional, where, you know, one of the catalysts for really having these recommendations start to become routine was early adopters. It was how many patients came in and said, you know, I was reading about this, I think I qualify for this, or I think I should get this, or, you know, somebody in my family had it. And so, you know, primary care doctors are busy, and, you know, they've got to try to balance prevention with acute care. And so this demand side can be very, very effective. You know, I mean, I remember we were having sort of a focus group and somebody said, you know, look, if they want a mammogram, all they have to do is ask. And I thought, well, that's kind of what's been going on. And then eventually they start making this part of the normal routine and saying, and by the way, you need to get a mammogram. Right now, people who currently smoke and formerly smoke aren't that active. They do not see the doctor as often. If they formerly smoked, they're kind of invisible. So what we have not had is the awareness raising in the popular media. I mean, imagine women's magazines and mammography back then. We just have not had those kinds of targets. So the few surveys that the ACS has done has showed a startling lack of awareness that these tests even exist among people who currently smoke and among people who formerly smoked. So, you know, it's one of those things where if it's not getting brought up, it's not going to get brought up. So the EHR tools are not a whole lot of help right now.
Well, and I will just kind of build on that. In addition to that, I think one of the things we did learn from colorectal and breast and many of the others is the provider recommendation had a big impact on whether people would do something. And so making sure that our providers and healthcare professionals really know the guidelines and know who's eligible and the questions to ask and how to engage in an empathic way with people about lung cancer screening, I think is going to be really important, and kind of making it part of the normal conversation. Hey, let's talk about cancer screenings. And these are the ones that we can bring up to talk about. If you want to explore them further, even then refer them out to a lung cancer screening program who can do additional support. You don't have to do it all in a primary care setting, but I think helping folks say, this is a normal cancer screening to talk about, just like all the others.
I'd just like to add, as a primary care provider myself, we can't think about any of these questions of implementation in a vacuum. I mean, we are truly in a crisis of primary care. We do not have enough primary care to meet the needs of our population. And for a number of different reasons that are beyond the scope of the seminar today, we've made the job, really difficult. And that's partly administrative burden's been pushed back to the primary care doctors. So I really want to support, Jennifer, your suggestion for team-based care, but with a little bit of a tweak. I really believe that team-based care is best located within primary care. And that's based on an observation across a number of different chronic disease conditions where it's sometimes hard to get a patient to go somewhere else, metaphorically, if they're not familiar. So if you can do the shared decision-making and education in primary care, we found that reduces the metaphorical distance to the lung cancer screening facility. I don't think that's the only approach, but I do think it's one that we need to encourage, and one that we, definitely pursued in our FQHC-based work in Austin, where our patients have a number of barriers between making the decision to be screened and actually getting screened. But, as a primary care provider, team-based care here with a navigator who both helps the patient in understanding the underlying proposition and then in the practical steps to achieving it has been the secret sauce in my experience.
Nikki, I saw you smile there. What were you going to say?
I absolutely smile, because I do think that team-based care is absolutely important, and that navigator does play an extremely important role into helping the patients understand what the screening recommendations are, that they are annual recommendations, that they need to come back. And I think that's where we also have that opportunity to really talk about, to use that language that destigmatizes smoking, so that people don't feel like that's a barrier for them. And so I do think that is one of the places that coalitions can really play a big role, is in really helping to provide the navigator resources that are necessary so that the navigators can work well and comfortably in that space.
Great. Thank you all. I see a few questions that I'm going to take from the chat that kind of have a common theme, is CMS requirements for payment and insurance prior authorization before approving an order, and the likelihood that private insurers will balk at supporting lung cancer screening for someone 78 to 80 years. Bob, do you want to tackle the dance we have with, people's concern about insurance coverage and promoting something that they might have a hard time finding?
Yeah, well, there's obviously an opportunity for advocacy across the different plans. I mean, private health plans do not have to restrict screening to, patients who are within a window of 15 years since quit. But we have to promote the logic of why they would want to go beyond that. CMS supports screening up to age 77 because people who enrolled in the NLST were 74 when they started and 77, at their oldest, and 77 when they exited. I mean, this is folklore that people have come to learn over the years as they made that decision, because they just said, well, there's 77 at the end of the study, so that probably means it works up to age 77. So there's no reason to believe that it would stop working at age 78 or 79 or 80. The only challenge is your patient a candidate for screening? And our guideline update even says there's nothing magical about the age of 80 if you've got a very healthy person who's never been screened, or for whom you think, 1 or 2 or 3 more years of screening is probably a good idea. But the burden then becomes on the primary care, the referring physician, to ensure year after year that patient still is a candidate, because things can happen. I think raising awareness is going to be as big a challenge for the health plans as it is for everybody else. I mean, most of the health plans are small. It's not like they're all just big giant ones. They all have smaller plans. Anybody who's tried to get a handle on what plans offer in their state, and people would say, well, which ones? So it's a big challenge. So I think it takes some work. I mean, I feel that this is an important part of the evolution of lung cancer screening. This is not a guideline where we differ. It's not that we disagree, because we're the first ones to really dismantle the underlying epidemiology of years since quit. And I think, people, we're just the ones who took it on. Others are going to start taking it on from this point forward. So ideally, the sooner people can come to terms with the fact that risk actually isn't dropping, it's rising, and probably will be able to turn this one around and be able to continue screening people as long as they're in good health.
What's a little bit relatively, I won't say unique, but fairly special about lung cancer screening is it's a huge amount of benefit, but also a moderate amount of harm. And I think providers get very anxious about, no one wants to recommend someone to something and then have them have a bad outcome related to the screening process. And my, as a medical director of both colorectal and lung cancer screening programs, my colorectal cancer screening program runs fairly autonomously. We have a meeting every couple of weeks. It's good. But our lung cancer screening program is so much more complex because the people that qualify for lung cancer screening by either set of guidelines are just medically more complex than the 50-year-old who's getting their first colonoscopy, or 45-year-old for that matter. So I think you can't neglect that dynamic. And I think, as Bob mentioned, the thing that I worry most about for my implementation science hat and these new recommendations is just making sure that there's good decision-making happening for the older people who, under the new ACS guidelines, will still be good candidates for screening, assuming they have enough underlying health and longevity to benefit. And that's I've worked my whole career, mostly in colorectal cancer, about that part of the decision-making. And it's really hard to do that well. Providers are really uncomfortable talking with their patients about life expectancy. Patients are oftentimes not, real comfortable talking about that. So that's the area I think we're going to have to really do some extra training and work on if we want to do this well. Because what we don't want to see is, the person that is in hospice from their other cancer or has an ejection fraction of 10% getting a lung cancer screening test, an abnormal finding, and it having no opportunity to improve their quality of life or longevity, but it just adds to their care complexity mix.
Yeah. So
that's not happening, by the way, right now. I don't think,
right.
Remember, we're at a very low degree of screening, but that's, I think, the thing that we worry about a little bit.
Yeah. Well, this is just to add on to what Michael was saying. We don't have a system in this country of cancer screening. We have opportunistic screening, which means that we don't have the opportunity to steadily and with oversight improve quality. Right now, lung cancer screening by many is believed to be just plagued with false positives, when in fact the recall rate is right now very similar to breast. And that's not saying that the breast cancer recall rate is okay. It's too high also. But the fact is that after that first screening examination, if the patient returns in the following year, which also is not happening, that recall rate is going to be much lower. So we need to reassure clinicians that this examination is going to have some growing pains, just like every other examination has. People have to learn how to do this and learn how to do this well at every step in this process. But it has enormous benefits compared to even the other cancer screening tests in this particular group at very high risk. The number needed to screen to prevent, one death is a fraction of what this is for the other cancers, and they're quite acceptable from public health standards.
Thank you. There's so many great questions coming up in the chat. This might steers a little bit towards cancer planning, but in general, what guidance, Brad asked, what guidance can you give to those of us who do community and advocacy work on how to communicate this information to policymakers and the public at large? What is going to be our key point and our elevator pitch? I love it. And that I say, I think of the cancer plan and the strategies that we all want to include, that secret sauce to getting the right information to the right people at the right time who are making decisions. Jennifer and Nikki, any thoughts?
So I have lots of thoughts, but I think that Jennifer is the absolute best person to convey them because of her firsthand experience. And so I will punt to you, Jennifer, because I do think that your experience is amazing in this space and very appropriate.
I think what you can say in these spaces, in an elevator pitch of sorts, is that lung cancer screening is an evidence-based screening. So you're not going to say that. We know lung cancer screening works in a particular population. And if you are a part of this population, then it is time to talk to your doctor about whether screening is right for you, and that you would encourage them to have that conversation with their doctor. I think one of the things that's so important as policy and advocacy, and as we look at all these things, we have a tendency in cancer screening to say, all cancer screening is good, go do it. And one of the things that people say if they don't fit in these guidelines is, that's not fair, I don't fit. And what we can say to them is, that's good news for now. You're not at the highest level of risk to benefit the most. And so let's focus on, we know what we know about those who could benefit the most from lung cancer screening. And so if you fit in these ranges, if you have ever smoked and it's been 20 years, a pack a day, if you have formerly smoked and you are in this age eligible category, go talk to your doctor. And just kind of keeping it real simple in that space, I think we can easily overcomplicate. And we don't need to make the recommendation you should get screened. We need to let that be a shared decision making and to build that trust within that provider community. And that's where the people will come back again and again when there's trust there.
And then I'd also add that from a policy perspective, and in your conversations with policymakers and those who are making decisions, to really encourage you to use the cancer registry data, because you can pull that data down by congressional district, you can pull it down by county level, and you can work with your registries to help them to create one-pagers that really show who we're talking about in our community. And I think that that's where it really, really matters to folks, when they understand that we're not talking about national data, we're talking about our next door neighbors. And so I really encourage you to engage your cancer registries and your registry folks so that you can have the graphics. Not that we don't want the absolutely help provide, put paper in folks' hands that let them really see what that burden is and why this is important.
Yeah, I one thing I've learned from implementing a program is I've heard sometimes that when funders want to require that there be a rather detailed process to define the underlying eligible population, I think that's a little bit misguided. We're so low on the implementation curve, and understanding the true smoking history epidemiology is so hard that a lot of groups get stuck at that stage. I've kind of flipped it around and said, you just need to find enough pool of people to keep your program busy enough so it can get better at doing its job. And we found that when we started, that was like, 10 patients a month until we got our processes down was about what we were handling. Now we're doing 50, 75 and feeling pretty good about that. So you can get stuck at the part about assessing eligibility or not. But when we know that we're only screening 20% of the eligible, flipping that around to how do we get in front of those people so we can get that message to them and help them to decide on an individual basis, that's where I think the energy is better directed. And then making sure that the back end of the process works, because the worst thing in the world is if you someone makes a shared decision and then they run into a bunch of logistical barriers, or they get a big bill that they didn't expect. So that has to be part of running a good program.
One of the things I wanted to ask you all, where are the biggest bang for your buck as far as our coalitions looking to work with providers, talk with providers, offer information? As a primary care provider yourself, where do you go for your CMEs, or who do you like to partner with to get that kind of information?
Yeah, that's a great question. I feel like trusted sources like the American Cancer Society do a really good job of getting that information. And, like in colorectal cancer, the lung cancer roundtable, I think has been really helpful to, be a place that, for the whole nation can act as a resource. And I guess I'm guessing your state cancer coalitions, we were able to do some of that work in Texas as well, so that you have a group that's learning from one another in implementation. That's pretty important to me. But it's not a knowledge gap, really. It's how do you fit this into an already over busy, set of work tasks. And I think we've got to find ways to be able to pay for that navigator, that person. Maybe they navigate across 4 or 5 cancer programs in a, you know, small to medium-sized practice, especially in communities that face a lot of barriers, financial, transportation, you know, educational barriers. You have to have somebody, people can't just do it on their own, you know, for things that are new like this.
Thanks for that. Bob, what are your thoughts? You've done a lot of work over the years with the roundtables and educating providers. Do you have any best practices you'd like to share?
Well, certainly people have got to be aware, but I think the most common best practice is that an army of one is not going to get the job done, and that every time we'd like to stress, and it's unfortunate that and there's probably other barriers, but payment models don't support medical homes. Payment models don't support team-based care, and most of the time patients pretty much understand if anybody in the doctor's office recommends something, they're not just giving you their opinion, they're acting as an agent of the practice. That's certainly, we got this insight when we did some analysis of patients in Kaiser. They basically, if you've got a message from Kaiser, it's like getting a message from your doctor. If I get a message from my insurance company, I'm wondering, what's this for and whose idea was it to send it? So the idea is that if you don't have a system where not only the people operating in the system, patients and healthcare workers are understanding with a set of rules, roles, and relationships, everything's going to be ad hoc, which is going to mean most of the time in lung cancer screening, it's not going to get done. So we have seen in colorectal cancer screening, we had federally qualified health centers that looked at their colorectal cancer screening rates and were horrified, because if you were to say, are you doing a pretty good job at this? They'd say, of course. Look at your rates and no, we're not. And so essentially everybody gets deputized to bring this up. And the more within a practice, the more people who bring it up and reinforce that. We saw rates in a year or two triple, quadruple, just simply as a result of making it a bit of a campaign in the practice. So at this point in time, there's really no substitute for actually asking your patient if the questions that would indicate whether or not they qualify for lung cancer screening. People say, well, ideally the electronic health record will take care of that. It's not going to populate that information on its own by reading the patient's mind. Somebody's going to have to enter it eventually. So it's not that hard. And frankly, for decades, we've wanted to ask and insisted on asking patients whether they smoke or not, because if they did, we want them to quit. Now we need to just quickly gather that history, and there are more and more efficient ways to do that. And the more we make the equation of years and years of smoking and pack years and years since quit, the more we make that less complicated, the easier it is going to be to gather that history.
Thanks. Interesting question, kind of as a follow-up to that from the chat. Are there ROI case studies for primary care clinics that coalitions could access and share to help new programs avoid billing and reimbursement issues, especially when they're sharing care with an LCS radiology facility?
I don't think, honestly, that the current structure of payment does support it as a financial case. It's more like you've got to say, we think this is important to do, and we're going to do it because we think it's important. It is not financially lucrative to spend the time. I think there's some ways that if you are well organized, you can mitigate the the financial burden, but it's not going to be because it's a great deal. The other point I just really think that's related to that is we've got to work at a policy level to reduce the uncertainty about the downstream testing. So I think pretty well we've solved not getting people get bills for the screening that's billed under the screening codes. But I don't feel as confident that we can make sure that people across various different insurance products don't get bills for the 3 or 6 month surveillance scan that people might need, or the biopsy, and then also looking at how much variation there is across plans, and if they need to go on and have cancer treatment. I mean, the goal of this program is to get people to lung cancer surgery, right?
Yeah.
That's how we save lives.
Mhm.
So you have to have access to lung cancer surgery to be the distal end of this process.
Mhm.
Yeah, so let me just add very quickly that the ACS, well, the Roundtable, National Lung Cancer Roundtable, ACS National Lung Cancer Roundtable, does have a free software program for estimating your investment and your return on investment. And we built it in such a way to pack it with as much high quality features, including adequate navigation, and even how much free care can we build into it and still have us not go into the red. Turns out that it's quite lucrative to have a lung cancer screening program. The whole point of this program was not that is to avoid that the best you could do is get an old scanner and then maybe get some radiologist time, to run it. It's you want to develop a program. The other thing is there needs to be incentives for primary care that are better, and strategies to support primary care. The third thing I was going to say is we get a lot of pushback when all of a sudden you're going to measurably increase the number of people who are eligible. But as everybody saw when we dropped the age to recommend screening for colorectal cancer from 50 to 45, not every 45-year-old showed up at the hospital the next day, for a colonoscopy. You're going to have capacity increase when you feel demand. It's not going to increase in anticipation of demand sometime in the future. So what we have to do is find ways to steadily increase this throughput, and the capacity ought to increase. Ideally, will increase if we do that.
Thanks, Bob. I will mention something that I see coming up in chat is how do we elevate this from a policy perspective? And Jennifer, if you wouldn't mind kind of taking a stab at that as far as how you guys approached it in Kentucky. Not only did you raise screening rates, but you were able to get a lung cancer screening program from state funds. Could you talk a little bit about how you were able to elevate that at a policy level there?
Absolutely. Now, this could take the rest of the time. No, I won't do that. But essentially, I think what started was our coalition coming together to create a lung cancer network, a roundtable, a task group, whatever you want to call it, that said, we want to do something about lung cancer, an infusion of funds from many different places, putting it in our cancer plan, elevating the conversation. And so where we had people saying, I care about lung cancer. And in many ways, they were folks around not just the lung cancer screening space, because that was kind of new. That was in 2013, but it was also people in the tobacco treatment space and the radon prevention space and the secondhand smoke space coming together. And we realized, boy, we're a team. We didn't even know it in those places. And so I think elevating that conversation and then doing stuff together, getting in the communities, getting in the state, kind of connecting and having these conversations among the primary care, among the different folks, elevated the conversation. And so then policymakers were like, we need to talk about lung cancer. And to Nikki's point, if you start looking at the data and unveiling the data for cancer in your state, you're going to very quickly say, oh, what can we do about lung cancer? Is there anything we can do about lung cancer? And then the policymakers can say, well, if we can do something, let's do something. And then we have stuff you can do. So, people were saying, hey, for colorectal cancer, we have this great program. We have all this stuff. And then we had a representative say, why don't we have something for lung cancer? Isn't there something we can do about it now? And so then because of the coalition, because of the engagement, because of the conversations, people knew who to come to ask the questions, to find the experts, to really inform the development of policy to create a statewide lung cancer screening program and an advisory board that is moving in that direction. And so I think those relationships, and you guys are already doing it with policymakers, letting them get to know your cancer plan, letting them get to know your cancer data, letting them know about there is something we can do about lung cancer. And we want to care about all our people who are at risk for all kinds of cancers. And here's an opportunity to do that and to do something. And then to dive in deeper to say, this insurance steerage stuff, not cool. Hey, this kind of not funding navigation, what's going on with that? Michael brought up a point about funding primary care. If they're a standalone entity, which many are not anymore, they don't get the benefit. It's the lung cancer screening hospital system that gets the benefit because that's where the money comes in. So how do we share that benefit so that everybody benefits in multiple ways? And so I think there's policies around all of these different aspects, and we as coalitions can be a platform to have the conversations about the policies and to let them talk about what those can be, and different people can take leadership in moving that forward.
Jennifer, yes, go ahead, Michael. Yes, please.
Just to make that even more audacious, Jennifer, I think we need to start talking about, our goal is to make lung cancer a rare disease. 200 years from now, people are going to look back. What did we do for that 100 years where we, created this huge amount of smoking related morbidity and mortality? It's been a scourge on our country my entire life. But I think we can see an end to that. And we won't get rid of all lung cancer, but make it a rare disease. Right now, it is such a bigger problem than the cancers that are in people's minds commonly. Just really hasn't gotten the attention. I think the question of stigma, Nikki, I think you raised that earlier, is really important. There's a lot, of even self-stigma, and we have to help overcome that and really get to the point. So linking intensive smoking cessation and other tobacco control efforts along with screening, making sure that we look at people's cardiovascular risk when we engage them in a cancer screening program. More people in the NLST died from cardiovascular disease and lung cancer, right? So as a primary care doctor, attending to the whole person care while putting particular effort towards moving from 20%, let's get it to 50, let's get it to 70 or 80. We did it over the length of my career in colorectal cancer. We can do it in lung.
I love it. Love it. And Jennifer, if you wouldn't mind just pulling up, I think you told me you had an example of cancer plan objectives and strategies that were in, is that correct? Okay.
Yes. Yeah.
And go ahead.
Yep. No, these are in process. I will say right now,
Okay.
This is not live. Elaine, if you're on, don't worry. I'm not publishing our cancer plan today. But I thought it would be relevant to kind of say the conversations that we're having for the longest time since I've been doing this for 20 plus years in this space. Our cancer plan objectives have focused on the screening. Let's change the increase in screening. And while that is an okay place to be, sometimes it gets confusing because then you say screening by which guideline and what are we doing? The ultimate goal of screening in an evidence-based way among the populations at risk for screening is to detect it early or to detect it before it becomes cancer. And so for Kentucky's plan, we're kind of saying, hey, we need quality screening as part of key outcomes that move us in the direction of what we're going to measure. And that is looking at late stage or incidence overall or mortality. So you can see my different ones, but we are looking at breast and lung. We're looking at decreasing the percentage of late stage because of the type of cancer screening it is. For cervical and colon, we're looking at decreasing the incidence rate overall because we should be able to get it lower by the type of screening. And then for prostate cancer, really decreasing the mortality rate from cancer, knowing that it's a little more complicated, but just increasing screening doesn't automatically move it to decreased decreased incidence. So this is kind of the direction we're going. We're also looking at health equity. And so diving into our data, our cancer registry data, our BRFIS data, and saying for Kentucky, where are there disparities? Where are there things that need to happen? And so for some cancers, it's among our Black Kentuckians. For some cancers, it's among our rural and Appalachia Kentuckians that are the highest need to consider. So that's just something we're chatting about.
Bob, I saw some questions about, and I hear exactly what you're saying, Jennifer, about screening and not maybe being focused more on reducing late stage, but someone did have a question about finding lung cancer screening state numbers. Do you have thoughts about that, about a lung cancer screening registry, how BRFIS is coming along in this area?
You can get numbers from on the College of Radiology's website from their lung cancer screening registry. It's a little bit tricky to track them down, but you know how this works. You just have to keep moving around and clicking on things, and eventually you find these large Excel tables that will tell you some very interesting data, frankly, as to the number of exams that were done that were reported to the registry. Last year, the BRFSS added lung cancer screening to the rotating core. So those numbers are going to start coming out this year. People have the data, they're starting to analyze it, and we'll start seeing a number of papers on what what the national rate of lung cancer screening as reported to the BRFSS was. And that's going to be great because we've just been kind of in the dark since 2015 with little bits of data here and there. I mean, we've tried to estimate this from the lung cancer registry, but there's some question as to how many facilities are actually reporting. So we've done the best we can, but we're going to have BRFSS numbers going forward. But let me mention this also, is that when we looked at access to screening, geographic access to screening, based upon the number of facilities that were reporting data to the registry, we saw that most people in this country have access within a 40-mile radius of where they live, people who would be eligible for screening. 40 miles is not going to be easy for everybody. And frankly, 5 miles is not necessarily easy for everybody, but it's a benchmark. And this is where these numbers actually take on some meaning, because about 95% of the people in the country have access to screening within 40 miles. Only 75% have access within 40 miles in rural areas. Roughly 1 in 4 people are outside of that radius. And so this is another thing that a state-based coalition can do, is to try to highlight where in our state is there probably a group at even higher risk that has lower access to lung cancer screening, especially a problem in rural areas with the rate of hospitals closing. And this is a group that's going to require special attention.
Thanks, Bob. I know we're winding down to a close. If you wouldn't mind pulling up the poll while I'm going through these final slides. And thank you so much to our panelists for sharing your...
Katie, just before we leave, I do want to share reminders that, this is also the time that we really should be reaching out to our national partners. The American Lung Association has partnered, and they have this lung cancer screening toolkit that they've partnered with MD Anderson with, and they are, their local affiliates are available to help us. So I really do encourage you all to think about who are the other national players who are working in this space with us, and bring them on board, because they would really love to help as well.
Yes, thank you, Nikki. And that's a great segue. I'm flashing up on screen here. The Comprehensive Cancer Control National Partnership put together a lung cancer screening cancer plan tip sheet to help you as you think about revising your cancer plan in this area. They do have a list of partners, just like Nikki said, with the ALA and other folks that want to help. I will tell you that Lung Cancer Screening Awareness Day was widely supported on the 11th, that we had a 45% increase in those that participated. And we do have a special toolkit for those that are looking to promote lung cancer screening now and in the future. Jennifer alluded to this state initiative planning tool that's on the National Lung Cancer Roundtable's website, which is also super helpful. And then I also want to mention that we have some sister networks funded by the CDC, and I have them listed here. We'll send you the live links in a follow-up webinar, or excuse me, in a follow-up email. These are folks that have expertise in specific populations, and they're looking to help prevent and control tobacco-related cancers, of which we know lung cancer is one, in those special populations. So even though it might not be screening based, they are partners that would love to come to the table and help you better understand how to reach the populations that they're serving. So I just want to say we have partners at the George Washington Cancer Center that have done a lovely job at compiling resources for Lung Cancer Awareness Month. So you'll want to visit them and look at all the links that they have. And of course, as Nikki represents CDC here, we'd be remiss to not say, talk to your program consultants. For those of you that are funded through the National Colorectal Cancer Comprehensive Cancer Control Program, you have a project officer that would love to help navigate these waters with you and point you to the assistance that you need. So thank you all for being with us. A special thank you to our panelists, and we will see you next time. Take care.